My name is Professor Tim Orchard. I am a consultant gastroenterologist at Imperial College Healthcare and I'm also the Chief Executive. And I have a long-standing interest in arthritic complications of inflammatory bowel disease, having done my research on that at Oxford and having kept up an interest subsequently. Axial spondyloarthritis is in fact quite a significant problem in inflammatory bowel disease. Up to 5% of patients that I see have evidence of ankylosing spondylitis, the most severe form of spondyloarthritis. But we know that up to 30 or 40% of patients can have sacroiliitis, which can be detected on either plain radiology or MRI scanning. And what's interesting is that a significant proportion of those do not appear to have progressive disease, but it can cause quite significant problems. And a key issue is to try and identify when a patient is likely to have progressive back disease and when you therefore need to intervene with treatment. The key symptoms to look out for are low back pain that's particularly prevalent in the morning and radiates down into the buttocks, morning stiffness of more than 30 minutes, and patients who have taken non-steroidals, and of course they're not widely used in inflammatory bowel disease, but if they do take non-steroidals, if they are an effective treatment for it, that is another good indicator of inflammatory low back pain. And that's quite different from the sort of mechanical low back pain that we all see a very large amount of. The key diagnostic now is an MRI of the sacroiliac joints, and it needs to be specially requested ideally to image the sacroiliac joints. If there is evidence of inflammation and sacroiliitis on the MRI scan and patients also have symptoms, then it's a very good idea to get rheumatological input and a baseline assessment. And obviously the ideal is for these patients to be jointly managed between gastroenterology and rheumatology. And that will definitely give the best outcomes. If that's not possible, then I think it's important to have input when you're thinking about changing medications. We do know that patients respond to the same medications in a lot of cases. So for example, the anti-TNFs are effective in both spondyloarthritis and inflammatory bowel disease. And in fact, the presence of sacroiliitis and spondyloarthritis can be a trigger for using anti-TNFs. But we also know that some biologics have differential effects on the two types of inflammation. Under those circumstances, if we're changing medicines, it is really important to consult with each other to make sure we give the patient the optimal medication. It's interesting that, for example, that the IL-12, IL-23 inhibitors such as ustekinumab are not effective for spondyloarthritis but are effective for Crohn's disease. And of course, patients who respond well if they have spondyloarthritis to the IL-17 inhibitors don't respond if they have inflammatory bowel disease. So it's important to get those differences sorted. And the other thing to note, of course, is that the doses of the anti-TNFs are different between the two specialties. I think a key is good communication once you've made a diagnosis of spondyloarthritis between the gastro teams and the rheumatological teams. And that level of communication and joint decision making is the thing that will deliver the best results for the patients.